Community-acquired pneumonia in the ICU is a decision ladder. Step fast, but step smart. First rung triage. Admit to ICU immediately if severe CAP is present by IDSA ATS. Septic shock needing pressors ICU bed, no debate. Respiratory failure requiring mechanical ventilation ICU bed, no debate. If no major, scan the minor criteria and overall trajectory: hypoxia, multilobar infiltrates, confusion, uremia, hypotension, tachypnea, low PaO2, FiO2. If the constellation signals impending crash, move them upstairs. Curb 6.5 or PSI help frame risk, but the IDSA ATS severe criteria drive the ICU call. Second rung diagnostics on arrival. Get blood cultures and a good quality sputum culture in all severe CAP admissions before antibiotics if it won't delay therapy. If we empirically covering MRSA or Pseudomonas, those cultures are mandatory. Add rapid viral testing as indicated. Document recent antibiotic exposures. Document healthcare contacts. Document structural lung disease to refine risks. Third rung, empiric antimicrobials now, not later. Severe CAP gets dual coverage for typical and atypical pathogens. Start a beta-lactam IV plus either a macrolide or a respiratory fluoroquinolone. Ceftriaxone 1-2 grams daily. Cefotaxime 1-2 grams every 8 hours. Ceftaroline 600 milligrams every 12 hours. Ampicillin, sulbactam 1.53 grams every 6 hours. For atypical coverage, I add a macrolide like azithromycin or a respiratory fluoroquinolone like levofloxacin or moxifloxacin. Fourth rung MDR risk check. Only broaden if risk is real. This is stewardship. MRSA risk, prior MRSA, recent hospitalization with IV antibiotics, known colonization, high local prevalence, add vancomycin or linezolid. Pseudomonas risk, structural lung disease, recent broad spectrum antibiotics, prior Pseudomonas, local resistance patterns. Add an anti-pseudomonal beta-lactam, piperacillin, tazobactam, cefepime, imipenem, meropenem. Fifth rung, stabilize and support. Target SpO2 is greater than or equal to 92% unless there is a reason to individualize. High flow, nasal cannula can bridge. Non-invasive ventilation can bridge. Intubate early for refractory hypoxemia or fatigue. Give fluids judiciously. Often about 2/3 of standard maintenance once resuscitated to avoid overload. Start vasopressors if shock persists. Control fever. Provide DVT and ulcer prophylaxis. Sixth rung reassess daily. Procalcitonin doesn't block starting antibiotics ever. Use PCT later with clinical improvement to help stop or de-escalate safely. When cultures and susceptibilities land, narrow fast to the tightest effective agent. Duration, many uncomplicated severe CAP cases can stop at 5 days if clinically stable with normalizing vitals and improving oxygenation. But with complications or confirmed MRSA or Pseudomonas, treat at least 7 days, tailored to source control and response.